Assalamualaikum everyone. I am Dr. Fizza Qambar from the Department of ENT Head and Neck Surgery at Cell Hospital Karachi, currently in my year 2 of residency, and I've come up with this video which contains a PowerPoint presentation of the applied and surgical ear anatomy and temporal bone anatomy. As ENT postgraduates and as medical students, the ear can come off as a challenge in terms of understanding. So a good knowledge of the anatomy is imperative to be able to provide care to the patients, to pass exams, to scrub in surgeries, and to have an overall concept of what we're dealing with. So without further ado, let's start with the presentation. The ear has the following parts. The orange part shows the pinna and the external auditory canal, which constitute the outer ear. The middle layer is shown in pink, starting at the tympanic membrane and ending in the medial wall of the tympanic membrane cavity. In blue, we can see the vestibular and cochlear part, which constitute the inner ear. The nerve supply of pinna is important for us to know. This part is supplied by the greater auricular nerve, which contains the helix, the antihelix, and the lobule, while the auriculotemporal nerve is going to supply the anterior part of the lateral surface of the pinna. This portion, which is known as the concha, is supplied by cranial nerve 7th and 10th, while the lesser occipital nerve is only just going to supply the inner surface of the posterior part of the pinna. The nerve supply of pinna is important for us to know in order to administer regional ear blocks or while anesthetizing the ear when coming across external ear injuries. They can be lacerations or road traffic accidents or any kind of injury to the external ear. The ear is related to a lot of structures. Superiorly, we have the middle cranial fossa. Anteriorly, we have the temporomandibular joint, the auriculotemporal nerve, parotid gland, preauricular lymph nodes. Laterally, we communicate with the outside world. Medially, the middle ear starts. Posteriorly, we have the mastoid tip and the mastoid ear cells, while inferiorly, we come across jugular bulb, carotid canals, facial nerve, etc. The tympanic membrane is a portion, basically it's a partition between the external auditory canal and the middle ear. It is positioned obliquely. Imagine that this is a coronal section of the external auditory canal and this is the pinna. So this is the tympanic membrane and it is going to form an angle of 55 with the external auditory canal. It is positioned obliquely, meaning that the posterior superior part is more lateral than the anterior inferior part. It is just at a distance of 2 mm from the promontory. So imagine how narrow this place is. It is pearly white in color, and the normal tympanic membrane is mobile with maximum mobility at its periphery. The umbo is the most reliable landmark, and when the TM is retracted, TM meaning tympanic membrane is retracted, we come across a few signs. The first one of which is the absence of cone of light. This is the normal cone of light, and in this picture, which is the retracted tympanic membrane, does not have that. The lateral process of the malleus is more prominent. The handle of the malleus has become more horizontal. The mobility is restricted, and you could see that the structures that are normally visible at the medial wall of the tympanic membrane due to retraction have come in contact with the tympanic membrane, and the tympanic membrane has just collapsed, and this is not how it should be. While talking about the middle ear cleft, we need to know the three important structures. First of which is the tympanum, which is the middle ear cavity. Anteriorly, we have the eustachian tube, and posteriorly, we have an ear cell system which is known as the mastoid ear cell system, which opens inside the middle ear through an adytus and the cavity in which the ear cells are present, which is known as the antrum. The relations of middle ear cleft are very important because at every boundary we come across very important structures in the head and neck. So superiorly, we have the temporal bone, which is housed by the middle cranial fossa. Anteriorly, we have the tensor tympani muscle and the eustachian tube. Laterally, we have the external auditory meatus. Inferiorly, we have the jugular bulb. Posteriorly, we have this opening, which is known as the aretus, which leads to the mastoid. And medially, we have the labyrinth, which is also known as the inner ear. So if we were to imagine the middle ear cleft as a matchbox, we would know that it has a lot of boundary, as we've just discussed previously. So naming the important parts of the boundary, laterally we have the tympanic membrane, which is positioned centrally. Superiorly we have the bony wall of the attic. Inferiorly we have the bony wall of the hypotympanum. The roof has a tegmen tympani, which is separating the middle cranial fossa from the middle ear cavity. The floor has a thin bone which separates the hypotympanum from the jugular bulb. It could be dehiscent in some cases. Anteriorly, we have divided it into three parts. The upper one third is pneumatized. The middle third has a eustachian tube and tensor tympani muscle, while the lower third has a bony canal which separates the internal carotid artery from the middle ear cavity. Medially, we have a lot of structures, naming the promontory, the oval window, the round window and its niche, the tympanic plexus, the facial canal, and the prominence of lateral semicircular canal. Posteriorly, we have other important structures known as the aretus to antrum, the fossa incutus, the pyramidal eminence, the facial canal, recess, and sinus tympani. The important landmark at the level of the lateral boundary of the middle ear cleft has a petrotympanic fissure through which the chorda tympanic nerve is going to join the cranial nerve 7. As shown in this picture, we could see that this is the left temporal bone. This is the petrotympanic fissure through which the chorda is going to enter the middle ear cleft. This is the glenoid fossa of the temporomandibular joint, and this is the tympanic membrane. Another important landmark at the floor is the inferior tympanic canaliculus, which allows the entry of the Jacobson's nerve, which is actually the tympanic branch of cranial nerve 9, into the middle ear. Now, if we had been imagining the middle ear cleft as a matchbox, but endoscopically, that's not how it seems. Categorically and endoscopically, we have divided the middle ear cavity into some regions. The attic area is known as the epitympanum. The floor area, which is below the tympanic membrane, is known as the hypotympanum. The area that is medial to the tympanic membrane is known as the mesotympanum. The anterior part of the middle ear cleft is known as the protympanum, while the posterior part is known as retrotympanum. This picture is going to show some landmarks which are visible if you view the ear endoscopically. Actually, it's showing a lot of important parts, and this actually shows this is just medial to the tympanic membrane. So this is basically the area of the mesotympanum. Now, coming towards the subdivision of the tympanum endoscopically. So all of this is basically available in books. What's important to understand is that the mesotympanum is only housing the long process of incus and handle of malleus, while the head and neck of malleus and short process of incus are not part of mesotympanum. They're parts of epitympanum. Hypotympanum is going to have a lot of other important spaces like the bony canal, which is separating the internal carotid artery and the jugular bulb, and an important landmark which is known as inferior tympanic canaliculus that we just studied. The retrotympanum has a lot of other spaces, each of which we will be discussing in the upcoming slides. The first of which is the Prusac space. So this space is a subcomponent of the epitympanum. It is bounded medially by the malleus neck, laterally by the pars flaccida, which is part of the tympanic membrane, superiorly by the scutum, and inferiorly by the lateral process of the malleus. It's important because it is the most common site of cholesteatoma formation, and because this is the part of the pars flaccida which retracts inside, and this makes a retraction pocket. This picture is showing the HRCT of a temporal bone in which we have outlined the Bru-Sachs space. So coming towards the retrotympanum, which is the complex structure at the posterior part of the tympanic cavity, the areas that we are interested in are the facial recess and the sinus tympani. This is again an endoscopic view of the retrotympanum. So imagine if you were looking at the tympanic cavities from a superior side. So this would be your lateral sides and this will be medial. This is obviously an axial view. So it has these two important recesses, or we could say spaces. For the first one of which is the facial recess. If you could see over here that it is bounded laterally by the chorda and the tympanic membrane. It is bounded medially by the facial nerve. It is bounded superiorly by the short process of the incus, which is located inside the fossa incudus, and this is all of this part is located lateral to the facial nerve. And over here, if you could see, this is the area of the sinus tympani, lateral to which is facial nerve, medial to which is the medial boundary of the tympanic cavity. In this picture, which is a coronal view, is just showing that sinus tympani is actually it's a triangular space located between two bones, two thin bones or margins known as the ponticulus and subiculum. This slide is saying exactly what we have just discussed in the previous slides. So it says that the facial recess is superficial to the sinus tympani and is separated from it from the descending part, this part of the facial nerve, which is the vertical part. It is important because one can approach the middle layer from the mastoid without disturbing the posterior meatal wall. And this is also one of those hidden areas where cholesteatoma can occur after surgery. So the surgeons needs to be extra cautious while clearing this area, because if they leave some air cells behind, the process of the disease would reoccur. The slide says that the sinus tympani is the most inaccessible area in the middle ear and the mastoid, and it can be a site of recurrence. It is a triangular space between the ponticulus and subiculum. Now coming towards the surface anatomy of temporal bone. Basically, the temporal bone is divided into 5 parts. This is the squamous part. This is the tympanic part. This is the styloid part. And we have the mastoid over here. The petrous part is located inside the brain, which is at the medial boundary of the temporal bone. This is the view of the skull base, viewed from inferior and superior sides. This again shows some of those important landmarks. So the tympanic part of the temporal bone is going to house some important sutures, namely the tympanomastoid and the Tympanosquamous suture lines. Basically, when the skull is being formed, the skull forms in portions, and between two different bones we have some suture lines. So the first one is the tympanomastoid suture line, which is located, if this is the mastoid tip, this is the mandible, and this is the portion where the tympanomastoid suture line forms. This is important because it is one of those landmarks through which we could locate facial nerve. This is the left temporal bone, which shows this is the temporal line, and this portion anterior superiorly is the part where the tympanic and the squamous part meet and make a tympanosquamous suture line. This is obviously the left temporal bone. McEwen's triangle. This is one of those important landmarks which is used to locate the mastoid antrum during surgeries. So if this is the superior border, which is that supratemporal line or supramastoid crest, as we can call it, and another line which separates the posterior superior wall of the external auditory canal containing the spine of Henle, and the third one is a tangent which joins these lines. This constitutes the surface landmark of the mastoid antrum in which we're going to work. An important clinical marker is the presence of cornus septum, which separates the petrosquamous suture, is the persistence of basically petrosquamous suture. It separates the superficial squamosal cells from the deep cells, and if we were to reach the antrum, it is important for us to remove all of this and the septum to reach the antrum. If the antrum has to be reached, this means the corner septum must be removed. If the surgeon does not remove the corner septum, that means he has not exposed the antrum sufficiently. And obviously that leads to an incomplete extentration of the mastoid cells in mastoidectomy, leading to incomplete removal of disease. The slide shows some of the important landmarks of the mastoid antrum. Posteriorly, we could see a sigmoid sinus running posteriorly and inferiorly. Anteriorly, we have the descending vertical part of the facial nerve. Anterior superiorly, we have the bony canals, which are semicircular canals, and a short process of incus. Superiorly, we have that plate of the tegmen mastoidium, which is separating the middle cranial fossa from the mastoid. It says over here that it is the largest and the most consistent mastoid air cell present, and it is of the same size in adults and children. So the friendly landmarks to identify during mastoid exploration are listed as below. This is pertinent to surgeries, and when we drilling in the mastoid antrum, we need to recognize a few of the landmarks that we need to expose in order to perform an adequate surgery. So the first of which is the short process of incus, which is held in the fossa and cutis of the epitympanum. Then we have the lateral semicircular canal. Superiorly, we must expose, or we must reach up to the dural plate, which is also known as the mastoid tegment, as discussed previously. The posterior boundary is the sigmoid sinus boundary, and the inferior boundary is the digastric ridge. So what is the Trautmann's triangle? It is the important landmark to reach the posterior cranial fossa from the mastoid. So if this is the dural plate, and this is the sigmoid sinus, and this is the vertical part of the facial nerve, and this is the part where you have your semicircular canals. So Trautmann's triangle, you could reach up to the posterior cranial fossa of the brain through this triangle, anterior to which is the semicircular canals. Posteriorly, we have the sigmoid sinus, and superiorly we have the superior petrosal sinus. What is the sinodural angle, which is also known as the Sitterli's angle? This is angle between the dural plate and the sigmoid plate. It could be low lying, so meaning that both of these are in closer proximity to each other. So this was some of those important landmarks and anatomical boundaries that we need to know. These are my resources. Thank you so much.